So the topic today is how to simplify perilunate dislocation. Okay, this I'm going to very basic how to read the normal X-ray, what you are supposed to see, and then we'll see the Mayfield's progressive perilunate disruption. So to start with, these injuries are complex and usually as a result of severe trauma. And as the literature suggests that their 25% are missed at initial presentation. This could be because of a polytrauma patient that needs urgent attention to other severely damaged part, and sometimes the treating surgeon is unaware of this perilunate dislocation and could lead to long-term functional disability and chronic pain. So this was one of the example where surgeon has fixed the scaphoid but completely failed to recognize there is a perilunate injury as well. So let's try and understand what is a perilunate dislocation. So as the name suggests, it is something around the lunate. And what is around the lunate? It is the other carpal bone. And these other carpal bones are attached to the lunate by means of their interosseous ligament or some extraosseous ligament. So in order to understand, let's go through some small normal carpal kinematics and small normal X-ray, what you are supposed to see. So I must thank Dr. Simon for sharing his 4DX motion on wrist range motion. So as you can see this during radial deviation, the scaphoid undergo flexion, and on ulnar deviation, scaphoid extend. So just to keep this remember for this point of time, otherwise this video will be extremely helpful to understand other part of carpal instabilities as well. So just remember scaphoid undergo flexion during the radial deviation and extend that's during the ulnar deviation. So what normal X-ray, when you see what you are supposed to look for? These are Glulas arc, scapholunate interval, and the shape of the lunate, which is normally like a rectangular shape. On lateral view, you are seeing the lunate, which is a half moon shape, and the sitting capitate. So you can correlate this capitate as like this. So this boy is a capitate, and this is sitting on the moon, and they are collinear with the radius. So this is how I remember. And let's now see the pathomechanics. This was described by the Mayfield in 1980s. He termed this as a progressive uh, interosseous ligament failure starting from the radial to ulnar side, and he described them into the 4 stages, and we'll see each stage in detail with some clinical cases. And as these are as a result of hyperdorsiflexion with ulnar deviation for an axial force, and as a result, as a complete disruption of the ligaments, the mid-carpal joint, the distal root, is pushed dorsally relative to the lunate. So let's see in stage 1 what happens. So in stage 1, there is a disruption of scapholunate ligament because of the hyperdorsiflexion and ulnar deviation, and there is a rupture of scapholunate ligament. As you can see here, the scaphoid is flexed and lunate is extended, assuming a form of dorsal DC deformity. As we have seen in that 4DX motion, the scaphoid undergo flexion on radial deviation. So there is rupture of scapholunate ligament, and scaphoid is assumed to flex, and lunate has migrated dorsally. So how clinically sometimes these patients have tenderness at scapholunate, and where do you palpate is your listus tubercle. Keep your thumb at listus tubercle, and the tip of your thumb is exactly pointing at the scapholunate interval. So there are tests, Watson tests, to check the integrity of scapholunate ligament. How do you do? Keep your thumb at the scaphoid tubercle and move your wrist from ulnar to radial deviation. As you can see that when you move your wrist to radial deviation, scaphoid try to flex, as we have seen that in 4DX motion video, and your thumb will push the scaphoid out of dorsal margin. This will be appreciated by patient as a pain or a click. So that assumes the Watson's test positive. How it looks like on X-ray? There is a widening of space between scaphoid and lunate. So there is a space increase, and this can be a term as a Terry Thomas sign, named after the British comedian. But this is not always present. you may have to provoke this when you have high index of suspicion that scapholunate is ruptured, and you can ask for the dynamic clinch fist view, which the same X-ray, if you see now, there is widening of scapholunate interval. So why this happens? Because in ruptured ligament, this capitate is trying to move and occupy the space between the scaphoid and lunate. So another sign is when scaphoid assumes flex position, it looks like a ring sign. So these are a few signs when you have a scapholunate rupture that you can see on the X-rays. Now coming to the stage 2, the deforming force continues and there is a rupture of ligament which are connecting the capitate and lunate. So the capitate lunate disruption occur, and capitate is forced dorsally with respect to the lunate. As you can see here, the capitate is moving dorsally. Remember the capitate, the boy is sitting in the lunate, half moon shaped lunate, now is moving out of his position, moving dorsally. Deforming force continues and there is a rupture of lunate and triquetral ligament. So whole of the ligament which are surrounding the lunate are ruptured now. An entire mid-carpal joint is shifting dorsally with respect to the lunate. How this looks on X-ray. Look at the green arrow. There is widening of space between lunate and triquetrum. The lunate, which was a rectangular shape, has become now triangular in shape. On lateral X-ray, look, the lunate is pointing volarly, half moon shape, and this boy capitate is now moving dorsally and is getting articulating with the distal end of radius. This triangular lunate looks like a piece of pie, so this is termed as a piece of pie sign. Now, stage 4, the most deforming force continues, and all ligaments have ruptured, and lunate is now moving out of his lunate fossa because there are some ligament attached volarly to the lunate. That's a radiolunate ligament, which will force lunate out of its fossa, and lunate will migrate into the distal part of forearm, and this stage capitate will come and sit with radius. This lunate looks like a spilled tea. So this is termed as a spilled teacup sign. So as we have seen, this is a progressive interosseous ligament failure from radial to lunate to lunotriquetral. So this is termed as a lesser arc injury, and as per the literature, this even if a treatment, this has a poorer prognosis compared to the greater arc injury. So what is greater arc injury? When the deforming force is started from your styloid, goes to the scaphoid, then capitate, and ends up into the triquetrum and ulnar styloid. So this is called as a greater arc injury. So let's have some clinical cases. This patient, somebody treated, as you can see on the X-ray, there is a scaphoid fracture, there is a perilunate dislocation. So this is termed as a transscaphoid perilunate dislocation. And somebody put him in a cast, and this patient had tingling in median nerve distribution. So this patient need urgent decompression of carpal tunnel as well as the definitive fixation for the treatment. So what you do whenever you see this patient in emergency room, you reduce them in ER, and this should be followed by a definitive fixation. So just here I'm just trying to show what how do you reduce. Actually, though it is just trying to mimic. So you give a longitudinal force, elbow flex, and keep your wrist under dorsiflexion, and then you push your lunate back to the lunate fossa, and then again you do a wrist flexion. So this is what I have done actually in emergency room. This is how it looks reduced, and this should be followed by a definitive fixation, which I'm not going to talk in detail. And this was his result at the end of 1 year. Some patient may present, as I said, these are high velocity injury, and this may present with the polytrauma. This patient had a lot of other issues like liver bleeding. There is a hemothorax going on, and this patient had open injury. Look at those carpal bone. Where are they going? They're maintaining their social distance. We don't want them to separate. We want, so put them back, fix them, and this was the result we saw early, and this was the late result. So some patient, as this was I've shown in first initial slide, this treating surgeon miss that there is a perilunate component as well, trans-scaphoid perilunate dislocation. So this was fixed only scaphoid and presented late. So this wrist has become stable, stiff, and painful, so which is needed some salvage treatment. So here the proximal row corpectomy where scaphoid, lunate, and tracheotomy is removed, and this was his result at the end of 3 months. So to conclude, in short, don't miss this initial presentation. Whenever they present diagnose, remember those X-ray signs, what is more like with Terry-Thomas sign, and rest subsequent what I have shown in earlier slides. So if you recognize them early, treat them with open reduction and ligament repair. Naked stage is the key to success, and whenever they presented late, salvage procedure are required depending on the patient functional requirement and what is the presentation scenario. I thank you, organizer, for giving this opportunity.